Nope. There it is.
Good evening, everyone. Thank you for making time to join us for Delaware Breast Cancer Coalition's In the Loop. And tonight's feature speaker is Dr. Tiana Polite Brown, who is going to give us the latest update on lymphedema.
Yes.
It is your floor, my dear. Take it away.
Okay. Well, hello, everyone. Good evening. Hope everybody's had a fantastic Thursday. I have. I've been very busy in the clinic, but I've been really, really, really excited to talk to everybody um, just about lymphedema and specifically breast cancer, lymphedema, and some other things too to look out for. I love educating people. I love connecting with people. So it's a blessing and an honor to be a part of this right now. So let me do the whole thing, share my screen. Boom. Hold here. Oh, it doesn't say. Oh, wait. Oh, Lord. We're going to get this done. Hold it. Okay, entire screen. We're just going to do the desktop.
There you go. Now you should be able to do it.
Okay, now I can do it. Okay, cool, cool, cool. Because it was being disrespectful for a second. I was like, wait a minute.
As
Entire
the day has gone.
open settings. Okay, I think I needed to grant access to this. This is my. Okay, we'll do that later. Let's try this one more time, y'all. We're gonna get this down. I made it all nice and pretty. There we go. Perfect. All right. Everybody should be able to see my screen. Let me make myself small and do my presenter view. Perfect. All right. So let's talk lymphedema, talking about pathophysiology, diagnosis, and emerging treatments with me, your host, Dr. Tiana Polite Brown. So, I am a doctor of occupational therapy who is a certified lymphedema therapist for over 7 years, and I am LANA board certified since 2024. And I also teach and certify other lymphedema therapists in CDT, which is complete decongestive therapy, oncology consideration for lymphedema, post-op and plastic surgery, lymphatic drainage, and all the other things. I have my bachelor's in exercise physiology from the University of South Carolina, go Gamecocks. And then I got my master's of occupational therapy in the University of North Dakota, go Hawks. And then doctor of occupational therapy from Creighton University, go Blue Jays. So I'm always in the sky, I'm always flying high. So I was certified through the Norton School of Lymphatic Studies, and I currently teach through Academy of Lymphatic Studies as well, and became board certified through LANA. And right here in this area, here's my LLC, Dynamic Occupational Therapy Services. That's my own kind of private practice and more so mobile when it comes to just educating people. So it's kind of what I am in a nutshell. I am a lover of Batman. I have my husband who's in the military and my dog Ace, the Bat Hound Brown. And I am also a daughter of a breast cancer survivor, Belinda Polite. She'll be turning 60 this year. Super, super excited. She got breast cancer when she was 21 years old. So I'll give you a little bit of background about that coming up in the next few slides. So, game plan. I had just starting with the lymphatic anatomy and physiology and treatment care. Skip that part about the lymphedema part. I forgot to take that out. And of course, a um, question and answer session. So, what exactly is lymphedema? Lymphedema is a protein-rich swelling that sits and settles in the tissues because the lymph system is not pumping and moving throughout the entire system. And so it usually comes distally and start to swelling at your fingers or at your toes, slowly creeping up towards the dorsum of your hand and of your feet, going to your ankles, and then going further up into the limb because it is hard to fight against gravity. You know, so lymphedema is considered a disease process and it is an abnormal accumulation of protein and water in the interstitial space, which is AKA the tissues. It is considered a mechanical insufficiency of the lymphatic system. I want you to understand the difference between mechanical insufficiency and dynamic insufficiency. So when you think of mechanical, you think of like a car, the transmission, there's something going wrong with the actual like heart motor of the car. And so if that's messed up, then everything else adjacent to it or connected to it is going to be messed up as well. So when it's a mechanical insufficiency of the lymphatic system, that means there's something wrong with the actual mechanics and the movement of the lymph system. When there's a dynamic insufficiency of the lymphatic system, that means that it's more so edema, that something else is happening, but the lymphatic system is able to help itself out, is able to regulate. So you just need to put gas in the car, right? That's all we need. We just need a little extra help to get that extra edema out. But if there's a mechanical insufficiency, we have to replace the whole engine. We're going to have to replace the transmission and the spark plugs. And even in that, that car will never be as brand new. There will always be some type of insufficiency going on. There'll be something wrong with the system long term. So, what exactly is lymph? Lymph contains water, protein, and white blood cells and cell fragments. Honestly, it kind of picks up everything. Um, I don't know if you're healthcare providers or maybe some of y'all who maybe learned about a little bit about the lymphatic system in school is seen as like the body's trash can. And so it kind of pulls everything to go along with it, kind of pulls everything throughout the body, travels everywhere, and picks up all the things that doesn't belong. And in a healthy lymphatic system, it picks up everything, goes along the extremities, and goes through and flows through your bowel and your urine. It's supposed to go out, get rid of all the stuff, and then keep on flowing. It's considered to be considered to be part of the immune system, and it's an open system. And so when we think of open and closed systems, we're thinking of what goes through and flows through. So a closed system is your heart, your arteries, your veins. The heart is your pump, and the veins and arteries are supposed to go through and flow through, pump the blood throughout, oxygenated, reoxygenated, and flow through the entire body, right? And it shouldn't be open because if you have an opening in the closed system, that's called a hemorrhage, right? But with the lymph system, it does have vessels and lymph nodes that it flows through, but it's very it connects to everything. And so it doesn't have a necessary internal pump that helps move it. So everything helps the lymph move. So the way that our heart moves, the way that our arteries are pulsating, the arteries do have that musculature that kind of goes like this. The lymph system is just hanging out, jumping with it, moving with it, just allowing, just literally going with the flow. And then the muscle pumping every time we move our arm, move our legs, pump our ankles, that is moving the lymph system. So it is very imperative that movement is very important. And we're going to talk about what type of movements and compressions and things like that to help move it along. But understand that the lymph system is very open and it goes along with and sits and settles and pulls from and pushes into the tissues. So when it comes to edema versus lymphedema, again, we just learned that lymphedema is the chronic accumulation of protein-rich lymph fluid to the impaired lymphatic drain due to impaired lymphatic drainage. And it is chronic and it is progressive. It usually is very gradual. It comes on pretty slow, but it may even develop years after a trigger. And we'll talk about what type of triggers can happen. And it is considered a disease and is treated with complete decongestive therapy. Edema is the body's normal response to an injury such as a sprain. Inflammation and fluid accumulates, goes down as the injury resolves. Movement when limb elevation and rest, it starts to go away. Once you kind of move it, once you kind of elevate it, and it'll start to dissipate. And then edema usually comes on pretty rapidly. And edema is considered a symptom, not a disease. So edema is a symptom, lymphedema is a disease. Where does it usually come from? So it's an estimated 250 million affecting humans worldwide. The most common cause overseas in small world countries or third world countries is the lymphatic filariasis. And that is when a bug or more so a mosquito bites a patient or bites a person and it infects this larva that goes into the lymphatic system. It pretty much wiggles through and tears it up and makes the vessels more enlarged and diseased and does not allow it to flow properly. That is where that usually happens in a third world country. Now, when it comes to the US, up to 10 million people, which I really think there are more because more people are learning about it, lymphedema is usually caused by surgeries. Most of them come from cancer treatments, such as the lymph node biopsy, and specifically the axillary lymph node biopsy removal, and or the radiation of the breast or prostate cancers that damage the lymph nodes. So lymphedema is usually caused by a surgical or intervention, the surgical intervention or treatment. So why is this relevant? So the lymph nodes are considered to be um, they cannot regenerate. So when you have the little bean looking things, those cannot regenerate. Once they're damaged during trauma or surgery or just over time, they can get fatty and fibrotic and don't drain properly. They don't regenerate. So when that happens, the fluid backs up and significantly impacts quality of life, morbidity, and healthcare costs. And it often goes misdiagnosed or underdiagnosed. Unfortunately, for a lot of our patients, the doctor, and I can't stand it, but I'm going to say it, the doctor usually writes you off as you being overweight or fat. That is what it is like, oh, you just need to work out more. Oh, take this diuretic, drink some more water, and that's what happened. That's not always the case. And these patients are at increased risk for skin infections such as cellulitis when lymphedema is left untreated. If the limb gets bigger and bigger, or even if it doesn't get too big, but that skin starts to change and it becomes more fibrotic and red all the time, a little nick, an ingrown toenail can turn into a catastrophic situation where you have to go into the hospital and get IV antibiotics and wound care, and sometimes, unfortunately, even amputation because the cellulitis has gotten to the point that they become sepsis. So it's very, 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 very important to know how to take care of yourself when you have lymphedema. So I don't want to go over too much because I don't want to take you guys back to anatomy class. But when we're looking at the lymphatic system, as you can see, it goes through and flows through the entire body. Now, there are lymph nodes in specific areas, but there are lymph vessels everywhere. Okay. So we talk about the lymph nodes, we have them primarily in the supraclavicular area right here above your clavicle, your axillary area, armpit. We have some in the mediastinum here, deeper into the gut area. And then we have the main areas here in your inguinal lymph nodes, right here along the underwear line or along the panty line. We have a few in the back here, popliteal lymph nodes in the back of the knee that helps drain. But as you can see, there are lymph nodes in specific places, but they're not in every single part of the body. Now, when we talk about the initial plexus and how the lymph capillaries are in the tissue spaces, as you can see with the red and the blue here on this picture, you have your arteriole, which is part of the artery system, and you have your venuole, which is part of the venous system. These are connected. But the green piece here is the lymph capillary, and that's what I'm talking about when you have like that open system that the lymph pulls from everything in between. It's not specifically connected to one area, but it's literally intertwined like a web that it's literally like a living being, and it's enmeshed with the tissue fluid. And so when we talk about the initial lymph plexus, you have different areas that the lymph nodes and lymph vessels penetrate. So it goes through, literally is only skin deep. And then you have some that go deep into past the tissues, past the muscles, and actually go right above the compact bone. So you have superficial lymph system and then the deep lymphatic system as well. So, this is where I want somebody to shout out at me. How many lymph nodes is one individual born with? It's a range. Who can tell me? Who can guess?
Thousands.
Thousands? Not that much. Somebody else. Don't be scared.
150.
I love your confidence, but no. It's 600 to 700 um, um, lymph nodes that one individual is born with. So it varies, but from all the anatomists, we're born with at least 600 and no more than 700 lymph nodes. And so we learned that our lymph nodes are not able to regenerate on their own, right? But the lymph vessels and the collectors are able to regenerate and kind of um, weave their way to do things. So they have an area that they've been stopped at. Then it's like, okay, cool. We'll just go this way and go over here and reconnect here. So the lymph vessels and collectors are very, very much alive and able to move around. But your lymph nodes, you're only born with a set few that are in, like we talk, specific places. And so when we talk about the lymph system, lymphatic system, your adenoids, your tonsils are part of the lymph system. There's Peyer's patches in your small intestine. There are in the red bone marrow is considered lymphoid tissue. The thymus and the spleen is considered lymphoid tissue as well. So there are like really big ones, and then all connect with the small lymph nodes that are in those specific places of the body that kind of gather in these areas. So you can be born with it. Maybe it's Maybelline. Like she's born with it. Like, yay, lymphedema. But it's not the greatest thing in the world. Or you can acquire it. So you have two sets of lymphedema. So primary and secondary lymphedema. Primary lymphedema is a genetic or developmental abnormality of the lymphatic system. And these are age ranges, Milroy's or Meniere's disease. And a genetic mutation can be inherited or developed when the lymphatic system is not fully developed. It can be um, early or late onset and is usually after a major um, hormonal shift. So, puberty, menopause, and pregnancy. So, with my story, my mom had breast cancer when she was 21 years old. She had the whole gambit. She had the surgery, the mastectomy, the double radical mastectomy, and she had the radiation and chemotherapy. And the doctor told her with all the stuff that she had going on, she was most likely not able to have kids. And then when she turned 24, here I come. But when I was born, I was actually my blood sugars were would spike up and then go back down. And so I had to stay in the hospital and I had to get tubes and stuff in my head. There are pictures of me with my head being shaved like Sonic the Hedgehog. That's kind of why my hair is kind of growing this way. But and so they got me regulated. I didn't develop, diabetes or anything. But one thing I noticed when I got my cycle around 12 or 13, I noticed that of course my body was changing, but my arms would kind of stay the same. Whether I gained weight or lost weight, I would never have any like shape to them, and they were always big to the point that people say your arms look fake. I said no, they're definitely real. um so then when I learned, I didn't find out till later that my mom had breast cancer. But when she told me about her
That's where
story.
you guys went.
Hmm? Melissa, are you saying something? I can't hear you. No.
You can
Okay.
go on. I think she accidentally
Oh,
unmuted.
got it. Okay, no problem.
Sorry
um
about that.
no, no problem. And so I when I asked her, I said, Mom, so okay, so what happened during that time? And so when I learned about the physiology and how the lymphatic system was, when it started from the mesoderm, the fifth week of gestation, and just learning about all the things that I went through when I was younger. And I was like, oh, I was most likely born with a faulty lymphatic system because the radiation was still in my mom's system, and it was also the steroids that she had to take and all the other medication that she was taking, not knowing that she could get pregnant. So no issue, no, no, nothing, it's not trying to, put blame on anything or on her, not at all. But it's just when I learned like about my history and my birthing history, it helped me think full circles. Like I thought there was something wrong with me. It's like, okay, maybe if I diet, maybe if I work out, maybe it's something that I'm doing. But my body just literally, once I hit that hormonal change, my lymphatic system was already I was born with already my lymphatic system under siege. Like I already had, it was already working. And but as soon as that extra estrogen hit, we women, we get hit with a lot when it comes to estrogen and progesterone and all the hormones that we have to deal with. It makes it makes the lymphatic system and our body work harder. So for me, that is when I was able to, when I learned about lymphedema and the difference between primary and secondary, I made that connection that, okay, I was most likely born with that because I didn't have any breast surgeries. I have not had breast cancer. I do my checks and everything else. And so that's kind of like my story. So, if you ever had lymphedema, whether it be lower extremity or upper extremity, and you may have noticed that one side was always bigger than the other, you had limb heaviness after a pregnancy, after your cycle, or after menopause or even perimenopause, you may have some primary lymphedema um, aspects. So got to get checked out. Now, secondary usually means you acquired it. Secondary equals surgery. That's what I like to say. Or secondary means something happened. So most secondary lymphedema patients had the lymph node dissection, radiation therapy, um, an infection, trauma, and it says or obesity because whenever you do have extra weight on your body, it can put more a heavy strain on the lymphatic system. But that's still we're going back and forth with that because I know things get better when you lose weight, sure, but that's not the one all be all. But for the most part, it's because something happened. There was still a trauma or a surgery to that limb that caused the lymphatic system happening. So the pathophysiology changes, physiological, I can't talk, pathophysiological changes. When the lymphatic system is dilated, you have a valvular incompetence, meaning that the veins are getting overloaded, too much pressure, too much fluid going into the area, then backflow, causing that lymphedema, tissue fibrosis, and chronic inflammation. So, when it comes to the breast cancer type, the lumpectomy and the I can't talk, the wide excision are usually not a lymphedema usually does not happen or it doesn't happen immediately because the smaller the area, the more focused the area where they took out the tumor and took out the skin, the less. But when you start to cover more surface area in a quadranectomy and a mastectomy, that's going into more lymph vessels and getting close to those lymph nodes that could be compromised. Now, when we talk about the stages of lymphedema, there are technically three stages. So, stage one, or still really stage zero, is latent. Stage zero, you really can't see anything, but you may feel a little bit of heaviness on one limb or even both. Some people unfortunately have bilateral lymphedema, either in the upper extremity or in the lower extremity. You notice maybe some numbness or tingling, but not much. You don't really know that you have lymphedema. You just have an idea like, hey, I'm starting to feel a little heaviness here. I'm starting to feel a little bit of shoulder pain because my arm is feeling heavy. Now, stage zero is reversible. You can see the difference. You can see, like in the second picture here, one side is definitely bigger than the other. Okay. You can see the start to have that pitting edema, the skin tightness, but you don't see any skin changes. Okay. And so with this, you can wear compression, or the reason why we say it's reversible because it can go away. You can elevate it. You can cut down, salty foods, sodium-rich foods, and then, it'll go away overnight. Now, when you get to stage two, it's spontaneously irreversible. This is when you see those skin changes. So stage two equals skin changes. This is when you definitely feel the heaviness, but you feel the skin thickening. You see the top of your hand start to kind of balloon here. You see that hump here at the top of your wrist. You see your forearm getting a lot thicker than the other one. And then when you get to stage three is the lymphostatic elephantiasis, meaning you have the heaviness, tightness, then skin thickening, and then the papilloma, I call it the papillomas, and keratosis. This is when you see the skin changes and they're irreversible. This is like when you have the brawny edema. It looks like the back of an orange. Um, and it looks, the skin starts to get red and dark in certain areas. And this is when no matter what you do, no matter how much compression you put on, how much lotion you put on, that skin does not change. And this is a permanent change. Now, the skin can get a little bit lighter and the limb can get a little bit smaller with treatment, but your skin will always be changed, unfortunately. So this is a video that may or may not work, but I'll show you guys a picture here. But pitting edema comes with either regular edema or lymphedema. The thing is, if you have pitting edema and it stays longer than, and that skin change and that indentation stays longer than 10 seconds, that's usually at the very least stage two lymphedema. Okay. And so this is when you're checking and you're pushing in, and this is how you kind of measure the grade where you have the 2 millimeter, the 3 to 4, 5 to 6, and then the 8. And then it also depends on how long it takes for that tissue to refill. So this is one of the criteria that I would do as a lymphedema therapist to check the limb if I do suspect lymphedema. And the interesting thing is you can have grade one, meaning you have barely any pitting edema, but still be at a stage three lymphedema because the skin is so hardened that it doesn't even refill. Like there's no tissue or no fluid that can get in there because the protein has just caused like a almost like a scarring of the skin underneath and just built it up, built it up, built it up. So again, difference between edema and lymphedema. Okay. Lymphedema is the swelling caused by an excess of protein-rich fluid trapped within the tissues. Lymphedema damages tissues responding to slow healing. So lymphedema does kind of mimic when it comes like diabetes type 2 and the slow healing. So because there's so much protein, it backs up the traffic that it's supposed to get to try to get the macrophages and all the things that it's supposed to kind of eat away the debris and help heal the tissue. That lymphedema is literally slowing up traffic to get to that wound so it gets worse and worse. Um, and it says lymphedema is can be harmed but not helped by treatment with diuretics. That's what I want you guys to understand. So if your doctor or your provider puts you on diuretics thinking that, oh, you're just, you just need to lose some weight or you just have some extra fluid on you, the reason why that diuretic doesn't work and you start to get worse and you start to swell more or the tissue starts to change is because now that diuretic is pulling all of that water out of the system, and now you're just stuck with the protein, and now the protein is overgrowing and building up in those tissues, causing that lymphedema to get worse. So if your provider puts you on that and it gets worse, I recommend stopping it. Let your provider know why you're stopping it and go to um your nearest CLT so you can start getting treatment. But when it comes to edema due to some causes can be relieved by diuretics. So like I have patients that have lower extreme lymphedema, but also have CHF, chronic heart failure, or history of pneumonia, or have chronic kidney disease, which is they have to be on a lifelong diuretic. And so I would have to work with the provider and say, hey, if they don't have to take two diuretics a day, can we at least lock it down to one so it can take off the fluid from the condition up here, but not cause too much of an issue with the lymphedema. So there's different ways that we can do it, but understanding and knowing why you're taking the medication. I've had conversations with providers and the patients too. It's like, okay, why are they taking this diuretic? Oh, it's because of swelling. Well, the swelling is lymphedema that's contraindicated. And we're able to stop that and they were able to get better. So it's a conversation with you as the patient and the provider and the lymphedema therapist being able to work with you. So when it comes to diagnosing lymphedema, again, clinical assessment with a detailed history, imaging the lymphangiocintigraphy. I can never say it. Cintigraphy. That's great, but it's very expensive. We will most likely see that in the UK, to be honest, which is really, really cool. It makes the lymph glow in the dark, and you can actually see the lymph fluid moving throughout the body. But it's also in most of the vascular centers, and that's usually for patients that have pretty intense vascular issues. The ICG, that is helpful, but it's very uncomfortable because you do have to shoot a dye in your vein, like in your hand or in the top of your feet, and that can be very uncomfortable. MRI and CT scans, those are more for differential diagnosis to see if they have any just free fluid in the area and checking for like DVTs and things like that. But how we do it is a detailed past medical history. I do the circumferential measurements at these different points, and then I do a physical exam as well. Now, when it comes to primary and secondary lymphedema, I pretty much learned that by just having a conversation with you. If you were to tell me, you came to me, you had a mastectomy 2 years ago, you were doing well, all of a sudden you went to the beach, and the one day you didn't have your compression on, you stayed in the sun a little bit longer, body got angry, you started swelling on the side that your mastectomy is on, and it never went away. That is more so secondary lymphedema. Primary would be, hey, I was doing well. I was an athlete. I did great. And then in my early 20s, I got pregnant and I noticed some swelling in my legs. My right leg never went down. I wore compression. Even after my baby was born, I was still swollen. That makes me think primary lymphedema. Now, I would still treat you the same way. So CDT is still very important, but we may do some things differently because of how you acquired the lymphedema. With a patient that has history of radiation, I wouldn't necessarily do ultrasound or red light therapy and all those things because that can reburn your skin. If you have primary lymphedema and you haven't had those things, then that could be another option. So treatment plan can vary differently, but it's really about the MLD, which is the manual lymphatic drainage, finding the right compression garments, doing the proper exercises, and educating yourself as well, and skin protection. So, if it's not lymphedema, what could it be? It could be lipedema, venous insufficiency. We also check for DVT. If I feel like your limb is really hot to touch, it's very painful. It came on all of a sudden, and I would send you straight to the ER to the urgent care to get urgent care that actually has a ultrasound machine to get that checked out first before I do any treatment. And then also it could be edema. Now, when it comes to lymphedema, there is no cure. It can be managed, but there's no cure for it. So I talk about managing your symptoms, managing your expectations, and improving quality of life. Again, the gold standard for lymphedema is the complete decongestive therapy. So the manual lymph drainage compression therapy using the right garments or bandages or some type of compression, skincare, and low intensity exercises. If your lymphedema therapist is not doing all of these things, you're not getting the full treatment. So compression therapies, there are multiple ones. You can do compression kits, reduction kits, compression sleeves, chip mats, foams. There's so many different things that you can do. The video is not quite working, so we're going to move past that. But these are some options. This one here on the, so I'll do my right, my left because it's the opposite. So I guess this is my left side here, or right. right here. The compression wrap kit. So that is like a Velcro wrap. There are some that can go just at the foot, some right at the foot, ankle, and the below the knee. And then as you can see, it goes all the way up. These are for people that, don't necessarily want to wear the standard compression garment, that may need a little bit more compression. They may be more active or less active. Very helpful. This part at the top here, this is the compression wrapping. This is what I would usually like to do first to really reduce that limb, whether it be your arm. I've even working on people that had a paniculectomy with, with their abdomen, getting the tummy tuck without the stomach, without the muscular part. And I've done that as well too with people that had tummy tuck or post any type of cosmetic surgery. So that type of compression, the high working, low resting phase compression is the best to really reduce that limb as quickly as possible, and then moving towards the standard compression. When you get to a place that you're at a plateau, when your measurements start to repeat itself. And it's like, okay, I think we've gotten to the smallest where we're getting to without any surgical intervention. And then we need to put you in something more permanent. That's me and my doggy, Ace-a-Boo. Um, I am one of the ambassadors for Lymphedivas. I love their products. I love their stuff. Very colorful, very fun. So that's my little shameless spiel there. But that's me and my doggy. If you have any questions about those, I can definitely send that out to you. So, when we talk about compression, could you use any bandage? Like I said, the lymphedema bandage, we want the short stretch, only 30 to 60% extensibility. We want it to be nice and tight. We don't want it to go all the way over here. Okay, we need a low resting pressure, but a high working. And so most people think, oh, you have ace bandages, ace wraps. Nope, they got that long stretch that goes all the way over here. And when you wrap that, that just turns into a tourniquet, or it doesn't have, because it ends up rolling, or it doesn't have enough compression to really contain that tissue to help move that lymph fluid the way it's supposed to. So getting the correct compression is key. Different options. You have the pneumatic compression devices. This one is specifically Tactile Medical. They have a great upper extremity system that gets the breastplate, the abdomen, gets the axilla, even in the back here, along with the arm. And so I do like working with them. Now, for me and for the standard of care, we would do this. Um, we would do this we recommend this at the end of treatment. So meaning you done your couple of weeks with me, we get you set up with a rep, and then you do this at home. I think I see a thought I saw a message somewhere, but I need to go back. Here we go. We would do this at home. Okay. Kinesiotaping, I love doing for patients that are, of course, not sensitive to adhesive properties, but for people that are claustrophobic. I've done it for patients that could not tolerate being wrapped because I'm wrapped for that long, because most of the wrappings, it's like we're wrapping you in three layers of materials to really reduce that limb. But K taping has done wonders. It does great on scar tissue, and it helps redirect those lymph vessels to get back into draining into those main places. Again, low level laser therapy. I've done red light and ultrasound on patients that had lymphedema and lipodema and lympholipedema to help break down some of that fibrotic tissue. But of course, they had to make sure that they did not have any radiation to that area, because we don't want to reburn the skin. Surgical interventions. So I say this. Surgical interventions are best done for the early stage lymphedema, for early stage lymphedema patients. So stage 1 and 2, and only secondary. So this is usually best for people that had they had a healthy lymphatic system, and they end up having breast cancer, and then they had lymphedema caused by the breast surgery. And so they have healthy lymph nodes that they can pull from and lymph vessels they can pull from to replace that. But if you have primary, meaning that you are born with a faulty lymphatic system, doesn't matter where you pull these healthy lymph nodes from. In theory, they're all um, faulty. So you're just putting one bad thing into another bad place. But there are some that do a great job. Most of the great surgeons, our best referred surgeons, are found in Florida and California. Um, they when it comes to a vascularized lymph node transfer, it uses the lymph nodes with the blood supply to the affected limbs. So it uses the lymph node, the lymph vessel, the vein, and the artery, and pulls from that one place. They pull it. So if you have upper extremity lymphedema, they usually pull it from the inguinal area, pull it up, and replace it here, and replace that one faulty lymph node, and pretty much replace it and supplies it, and it's supposed to move. Now, for the most part, it does work. But the sucky thing is, if you pull one lymph node from one working lymph node to another place, what happens to that area? Now, you could have lymphedema in your inguinal area because they pulled a lymph node from there. See what I'm saying? So there are some success stories. There are some people that have done, but you have to be in lifelong compression. You have to be in compression for 24 hours post-surgical for like 6 months for it to really truly work. So there could be more on that. Now, when we get to lipedema, there's a few slides on lipedema I want to go over. There's a high volume liposuction for lipedema that actually breaks down and sucks out the disease fat, because lipedema is considered to be a connective tissue issue that makes the adipose tissue diseased, and no matter what type of dieting or workout, it will not go down. So we'll go over that in a few moments. So, can you just get a regular massage if you have lymphedema? Yes, but you can also worsen your symptoms. Um, so a regular deep tissue massage might feel good, but it can worsen the symptoms of lymphedema due to mechanical overload. Again, we're going back to when I talked about the mechanics. Your mechanics are just they're overloaded, they're messed up from their from their core, so it's going to increase that fluid. So you'll be surprised, yeah, I don't have that knot in my shoulder anymore, but now I'm swollen. Now my compression garment is fitting a little bit more tighter than before, because now you really aggravated the lymphatic system. So I would say proceed with caution. The manual lymphatic drainage is considered to be a specialized technique to move lymphatic fluid from distal extremities to proximal lymph nodes in bundles to effectively drain the lymphatic system. So that is the massages you should be getting on a regular basis. But if you need a little extra, the regular massage, I like to do Swedish, still kind of get up in there, but then still, kind of do a little MLD afterwards. But for me, like with my upper extremity, I tend to get really inflamed, like in my shoulder area here, and I can tell the difference in my arms after a massage. So I have to be very mindful with it. So know your body, kind of see how you feel afterwards. But I try to put this little slide in to say, hey, still enjoy your life, but be careful. Of course, exercise modification. You don't. Now these are for people that there are some people that were already doing parkour and flipping tires and all that kind of stuff when they had lymphedema. They can do what they do. But if you have lymphedema and you weren't doing those things before, start slow. Avoid high intensity and high resistance exercises. Avoid the high heat environments. So hot yoga may not be for you because you're gonna fall out because it could exacerbate your symptoms of your lymphedema. So swimming is like the best um, exercise for anybody with lymphedema, whether it be upper extremity, truncal, or lower extremity lymphedema. Walking in water is fantastic. The water pressure itself is like 60 to 70 millimeters of mercury, just pressure, like you're walking in your compression in the water. It's fantastic. Biking is great too. Walking is good, making sure you have the correct walking shoes, and that you're not hurting yourself either, and just keeping it light. Um, So those are the recommendation I would do. Very simple. Arm pumps here, marching in place, ankle pumps. These are some of the exercises that I would do with my patients. Diaphragmatic breathing, belly breathing. It's also very important to do with patients with lymphedema. So when we talk about different effects of the body when it comes to breast cancer, most people don't think about how much radiation really does cause a lot of just ruckus, just messes with your whole entire system. Fatigue, nerve damage, sore throat, difficulty swallowing, color and skin changes, swollen lymph nodes, breast pain, peeling, dryness, shrinkage of the area, swelling, numbness, weakling, hair pit loss. So hair pit, Lord, armpit hair loss. So many different things that could affect you when you have radiation. Another one of the things is called axillary web syndrome. This is a common side effect from radiation and or from the lymph node surgery. And it causes refers to a cording that can be felt underneath the skin that can impair a movement of the arm. So we kind of know what causes it. Said the exact cause is unknown, but it's usually related to the inflammation and scarring of the lymph vessels after the surgery. Now, this is mostly from lymph node dissection. Now, if you had a lumpectomy, um, or a excision area, normally cording does not happen because it's in a small, more fatty area of the tissue. But if you start to go further into the pec area and then here, that's where cording usually happens. Cording is more frequent observed in younger individuals or those with a lower mass body index. Um, but it's common and it's very treatable. When it's affecting up to 86% of patients. So it appears to be a tender rope-like, visible, palpable cord that is extending from the armpit down to the inner arms to the wrist, causing pain. And so for these patients, I usually do like try to do the cupping thing, going here and pushing here and letting it hang, letting it stretch while you pull towards the area here. And then breathe, hold for 5 seconds, and then release. Another one is kind of put your head behind your back, let it stretch here, open up this cap, the shoulder capsule here, and then also stretch. And then also doing some median and ulnar nerve glides, like going across here, going here, and doing that to help glide that tightness out. So again, the psychosocial effect and quality of life impact. Patients with lymphedema have a chronic condition and usually at first, and me, when they say you, as in me as the CLT, I'm usually the first person to tell them this, or the doctor tells them, and then I have to explain to them what's going on. So understanding that body image and anxiety and self-management can all play a factor in the personal approach. It's uncomfortable. I don't like wearing certain clothes when I'm starting to get more comfortable in my body. I used to wear long sleeves even in the summertime because I didn't like the way my arms looked. I would be sweating and having to carry extra deodorant because I'd be sweating, I'd be hot, but I would not wear short sleeves because of the way that my arms felt. My arms didn't feel like a part of my body with my own personal lymphedema journey. So I get it. And just being educated, being comfortable in who you are, and being comfortable saying, "Hey, I don't like this. What can I do to fix this?" Is very, very important. So again, when we talk about lymphedema therapy, we have two phases. We got the decongestant phase, where we see you in the clinic. We do the skin care. If you have wounds, we do wound care, exercise, compression wrapping, the lymph drainage, right? Now, with the maintenance phase, we get you to the compression garments. We still would do the lymph drainage, or we would show you how to do it at home, or we provide you with a the lymphatic pump to help with the continuous lymph drainage. You would continue to do your skin care and your wound care, and you would increase the exercise component in the second phase. So, when we talk about lipedema, lipedema is a chronic progressive disorder of abnormal fat distribution that almost exclusively affects women. Yay. And it's often mistaken for obesity or lymphedema. So, Lipedema is always symmetrical. Lymphedema, one side is bigger than the other. Okay. So lipedema is always symmetrical. And it's a bilateral accumulation of the subcutaneous or adipose tissue, typically in the lower body part, and it's painful. You bruise easily, and it's always painful to touch. It feels like everything feels like a bruise and is resistant to diet and exercise. Again, usually worsened or triggered by hormonal changes in puberty, pregnancy, and menopause. It's very soft and doughy like. It doesn't really thicken like lymphedema, and it can worsen over time and develop into secondary lymphedema, which is lipolipedema. You can have both. So these are different stages as well, and then these are different areas. As you can see, lymphedema can affect your entire lower body. It can also affect your hips, just your hip areas. It can affect just your arms, and it can affect your hips in your pelvic area, and then sometimes you can just affect your calves and your calves and your ankles. Now, ankle below, usually people with lymphedema, one of the tall tale signs is they can have large legs but small feet. Their feet are not swollen at all. It stops right at the ankle up. So, you could definitely get an assessment and to check that out with your nearest CLT. So again, the differential diagnosis, clinical evaluation is gold standard. Like I said, lipedema is symmetrical and spares the feet and hands. So your hands, skinny, large arms, skinny feet, large legs. Lipedema. Lymphedema, usually the feet and hands are always um, involved. Asymmetrical always involves the feet and hand. You have pitting edema, and the stemmer sign is this picture right here where you can pinch and lift. If you can pinch and lift up the skin, that means that you have good vasculature, good connective tissue. But if you can't pinch it, like this other side here, it looks very, very large. That means that you have lymphedema. And that is it. So let me stop sharing my screen.